Welcome to this presentation discussing the basic cardiac investigations in children. Cardiac investigations include doing a chest X-ray, ECG for the patient, echocardiography. It may include also cardiac multislice CT scan, cardiac MRI, Holter monitoring, and sometimes we need to do table test and exercise testing. For the chest X-ray, please ensure there is a normal position of the heart and the patient is not having dextrocardia. Also ensure there is a proper cardiothoracic ratio. To calculate the cardiothoracic ratio, please calculate the maximum diameter of the heart on either side of the midline and compare it to the internal diameter of the chest. The cardiothoracic ratio should not exceed 55%. More than this percentage is considered cardiomegaly. Another important point for the chest X-ray in patients with cardiac disorders is the presence of pulmonary congestion. This might appear as kyphalization of vessels, which means that the hilar vessels in the upper parts of the lung are as big or even bigger than those in the lower parts of the lung, signifying congestion. Also, there might be a curly P lines in the periphery of the lungs, and there might be perihilar coughing because of the congestion of the blood vessels. Please ensure also that the patient is not having a concomitant chest problem, like the presence of pneumonia or pleural effusion. Also bear in mind that there might be special configurations for patients with congenital cardiac disorders. The Coeur-en-Sabot appearance of the Fallot tetralogy, a small heart with an uplifted apex, an acute cardiopharyngeal angle, and oligamic lungs. And there might be the egg-on-string appearance in patients with transposition of great vessels with a very narrow base of the heart. Also, another special configuration in cardiac patients is the snowman appearance, which appears in patients with total anomalous pulmonary venous drainage. Also, patients with partial anomalous pulmonary venous drainage might be a part of a scimitar syndrome, which can appear in the chest X-ray. For the ECG, it will be discussed in a separate lecture. And now we move on to the echocardiographic examination. The echocardiography views the heart from different acoustic windows with different views of the different structures to reflect any cardiac pathology. You must have a good understanding of the echocardiographic report, as you will see it in almost all patients following up in the cardiology clinic. In all echocardiographic report, you will find the fractional shortening, the FS, which reflects the systolic function, should be exceeding 28%. Also, the ejection fraction reflects the systolic function and should be ideally more than 55%. Another important parameter is the left ventricular end diastolic diameter, which reflects any ventricular dilatation, and this diameter should be z-scored, and a z-score more than 2 standard deviation is considered a dilated ventricle. Different online applications are available in which you can get the z-scoring of the different cardiac dimensions, providing the weight and the body surface area, age, and gender of the patient. Another important sentence that will start all echocardiographic report is the situs solatus AV and VA concordance. This phrase means that there is normal arrangement of the viscera. There is a normal relationship of the atria to the ventricles with normal origin of the great vessels from the corresponding ventricles. This might not be the case in patients with complex congenital heart disease. Then there will be a comment on the interatrial and interventricular septa. It will be mentioned if they are intact or if there is a defect. If there is an interventricular septal defect, you can estimate the pulmonary pressure from the pressure gradient across the ventricular septal defect, which reflects the gradient between the left ventricle and right ventricle. And hence, a high pressure gradient across the VSD means low right ventricular pressure, which means no pulmonary hypertension. On the other hand, a low pressure gradient across the VSD means that there is a high right ventricular pressure, which is reflecting a high pulmonary pressure or indicating the presence of pulmonary hypertension. Then there will be a comment on the atrioventricular connection, if it is normal or if there is some sort of atresia or a common AV connection as in this patient. Following the comment on the AV connection, there will be a comment on the ventricles and other structures as needed if there is a vena ductus arteriosus, the presence of a left-sided aortic arch, if there are any pericardial effusion or intracardiac masses. And make sure, please, to read the final conclusion, which will include the diagnosis and the opinion of the echocardiographer about the possible management of this patient. Guidelines exist on the optimal duration of transthoracic echocardiography in patients with congenital heart disease, but usually we do annual screening for patients or maybe earlier if there is an indication. In addition, other advanced cardiac imaging modalities are available. We might need to do a cardiac multi-slice CT scan for the patient, which is very good in defining the extracardiac structures and has the advantage of possible 3D image reconstruction. Also, the CT scan is very good in defining the coronary anomalies and is very good in defining calcifications. The cardiac MRI has the advantage of better visualization of the myocardium and defining myocardial pathology. Also, it is very good in defining pericardial diseases, and it is an excellent modality to differentiate between the different types of masses that might be seen inside the heart. Another frequently used investigation is the Holter monitoring. The Holter monitoring is an ambulatory ECG monitoring which can record the heart rate over a period of 24 to 48 hours. Some Holters exist which can record up to 1 week, but this is not available in our unit. Our devices can record up to 72 hours. It is important for patients with symptoms suggestive of arrhythmia, such as palpitation or unexplained syncope, but it requires patients to have frequent symptoms so that it can be recorded over the short period of 24 to 48 hours. Other ambulatory monitors, including the external loop recorders and the implantable loop recorders, are helpful in patients with infrequent attacks of arrhythmia, but unfortunately they are not available. Finally, 2 additional tests that are being used in the unit. The table tilt testing is used in patients with unexplained syncope. It measures the blood pressure and heart rate in different angulations with the patient's supine and then in the erect position. It is important in discriminating some types of syncope, including the orthostatic versus the reflex syncope, and it can be helpful in patients with cardiac causes of syncope. On the other hand, the exercise testing is useful in children who report symptoms related to exertion. It measures the heart rate, the blood pressure, oxygen consumption with different levels of exertion at the convalescence phase. It has some indications, but it has also a lot of contraindications, most importantly the presence of left ventricular outflow tract obstruction and the presence of acute myocarditis. And that's it. Thank you.